I can say, like, I can't believe you embarrassed me because you didn't get that in the States. Or something.
So I thought we'd warm up with the spaces of the neck, and I know you get great teaching here, but it's always good to get another perspective. This is a course that I actually did 10 times in a week. I was in Switzerland and teaching a group of Europeans, and I did 10 times. Every time I changed it a little bit, so I think it's almost perfect. Yeah, the objectives of the talk are to go through the anatomy of the neck. We're going to go through key levels, and you're going to get a sense of how I think, which is a little bit strange. We're going to look at some neck spaces, and then I have 7 core cases that illustrate the spaces of the neck.
It always does that.
Yeah, it's...
And then after that, there will be some pitfall cases that I see people get trapped up on, that I don't want you to be trapped up on. So with the neck spaces, why is it important? It's a small area, lots of spaces. 3 things. It's important for you to describe the abnormality accurately so your referring physicians know where they're going to operate or to treat. And then it helps you narrow down the differentials. We talk about this in head and neck all the time. If you know the space, then there are a limited number of differentials in the space. And then finally, in terms of malignancy, knowing your spaces and knowing where the malignancy spreads outside the space really helps with tumour staging and makes your reports a lot more sophisticated for the referring physician who's going to operate on that patient or stage that patient and decide whether the patient's operable or not. So in terms of general anatomy, the basic plan I tell people is that the neck is a cylinder, and it's comprised of the mandible, mylohyoid, and skull base at the top of the cylinder, and then inferiorly you've got the thoracic inlet. And then there are 2 big cylinders in the midline, which are the vertebral column and the cervical viscera, and 2 small cylinders off to the side, which is the carotid sheath, which is paired. The viscera, it's the larynx, pharynx, thyroid, and parathyroid. And then the cartilages that form the frame of all of that is the hyoid at the top. That's a really important bone. What landmarks occur there, Callum?
Landmarks.
Do I need to repeat you so you can be heard? Or they?
No, I can. No, they'll hear
They'll
me.
be able to hear.
They'll hear
We've got all these
Yes.
microphones.
Okay.
That's kind of where you levels of lymph nodes delineated.
Yeah, which
So
lymph
like
nodes?
2 to 3.
Yes, good. Tim, what else occurs at the hyoid? What happens to the pharynx of the hyoid?
So you change from the to the hypopharynx.
Oro to the hypopharynx.
Right.
Yeah. Okay.
Origin.
Yeah. What happens to the carotid at the hyoid, Davis?
The carotid at the hyoid. Is it bifurcate?
Yeah, that's where it typically bifurcates. Yeah. And then for head and neck radiologists, they often refer to the neck as the infra and suprahyoid neck, and the suprahyoid neck being much more interesting. And a lot of the spaces end at the level of the hyoid, and we'll learn about that soon. Okay, so then after that we've got the epiglottis, which is part of what? So the larynx, pharynx. What do you think, Davis?
Larynx.
Yeah, it's part of the supraglottic larynx, and that's that cartilage that closes over when you swallow so food doesn't go into your lungs. And then there's the thyroid cartilage, which protects your vocal cord, so when someone gives you a headlock or throws something at your neck, you don't stop breathing. And then the cricoid is the complete ring in the airway. Then the posterior space, the vertebral space, I'm not going to spend a lot of time talking about, but definitely Gabe would be interested in that in the future because he's doing MSK, right? Mm-hmm. Yeah. But bone, muscle, and spinal cord. Okay, and then the carotid sheath on both sides, which has the carotid artery, the internal jugular vein, and nerves. And the lymph nodes run along the carotid sheath, that's the jugular chain, but they're not strictly in the carotid sheath. Okay, so now we're going to look at 10 key levels in the neck, and we'll look at the anatomy here. And this is a bit like a Rorschach test. Have you seen Rorschach tests? Yeah, okay, so When I started thinking about how I teach head and neck to my residents, I knew it was a complicated area, so I tried to identify things that they would identify with. So the first level, starting from the top going down, this level I see a Durham bull, not a Carolina ram. Do you see the bull here?
I do.
Yeah.
Okay,
Yes.
so ears here, horn, and this is the snout. Okay, so Ali, tell me what all the contours are. What's this area where the ears are?
I'm not sure.
Okay. What about, and that's good because that means I can teach you something that you don't, that Sugata hasn't taught you already. What's this area where the nostril might be?
I don't know. It's right in front of the fossa prosimolar, but I'm not really sure.
Yeah, that's great. That's the fossa rosimolar. And that's also known as the pharyngeal recess. And that fossa actually goes down deep all the way here. Can you see where the mucosa is? In some people that's open, and this person it's closed, and it's usually closed. But it also means that if mucosa goes all the way down here, squamous mucosa, you can get a nasopharyngeal tumour that isn't visible superficially, that you as a radiologist will see. And you can see how close it is to the carotid artery. You can see it potentially encasing the carotid artery, and how close it is to this fat space here. What space is that?
The parapharyngeal space.
Yeah, okay, great. And this is actually the eustachian tube. And so that's why if you get a nasopharyngeal tumour as an adult, you might first present with a middle ear infection, which would be unusual in an older person compared to a child. Okay, and this contour here, do you know what that is? The torus tubaris. Yeah, and muscles attached to that to help open up the eustachian tube. What are these? What's this here, Gabe?
You have the medial and lateral pterygoid plates.
Yep, great. And what else is important here? I think that's about it. That's the nasopharynx. Okay. Gabe, when does the nasopharynx become the oropharynx? What's the landmark?
The nasopharynx becomes the oropharynx. I'm not sure.
Does anyone know?
Palate.
It's the hard palate. Yeah. So if you're imaging and you're still seeing the maxillary sinuses, it means that you're still in the area of the nasopharynx. Now we're below the hard palate, so we're not in the nasopharynx anymore, we're in the oropharynx now. And I think of this as my eating level. I love to eat. Here at this level, I've got everything I need to eat. I've got my teeth, the muscles of mastication here. What's this muscle, Sunny?
Masseter,
Yes, and what's this muscle here?
pterygoid,
Yep, which one?
should be your lateral pterygoid.
This is actually the medial
Medial
pterygoid.
pterygoid.
Yeah, the medial pterygoid is a big bulky muscle and it's
Okay.
lower down. The lateral pterygoid attaches to the condyle and it's a longer muscle. We
Okay.
might see that a bit later. We've also got a gland here. What's that? Parotid. Yeah. And what's this big vascular structure here?
That's not, that's, is that the, I'm not sure. Is that the lymph node?
No, vascular structure. Anyone?
Oh,
External
external.
external crown.
No, this is
Retromandibular vein.
Yeah, this is the retromandibular vein. Okay, this ends up being a really great landmark for you because the nerve that runs through the parotid, what nerve is that?
Facial.
Yeah, facial nerve runs from the stylomastoid foramen and it runs to the lateral aspect of this vein. So that nerve divides the superficial and deep lobes of the parotid, and if you can't see the nerve, which is usually the case, you draw an imaginary line from that stylomastoid foramen and the lateral margin of that vein. And if you've got a parotid tumour that's malignant, that's gone from superficial past that imaginary line, then you've got a high risk of perineural spread. The next level is the level you see if you open your mouth and say ah, because you see the tonsils, and here are the tonsils in the oropharynx. It's one of the big subsites in the oropharynx, common site for squamous cell cancer. And rather than seeing just the top of the tongue on that other image with all the amalgam, here we're starting to actually see the lingual septum, and further down we'll start seeing the deep muscles of the tongue, or the extrinsic muscles of the tongue. At this level we've got the submandibular gland, which is also great for eating. This muscle here, what's that? Sternocleidomastoid, yeah, great. And that's itself a muscle that is an important boundary for lymph nodes. Anything posterior to that is going to be where the level 2 becomes the level 5. Okay, this level looks like an ice cream. Can you see it? Yeah, there's a cone here. And this is the creamy part. What's separating the cone and the creamy part? Epiglottis, great. And then at the top of the ice cream, maybe the whipped cream, you've got the base of the tongue. And these are the lingual tonsils, whereas the tonsils that I was talking about before, they're the palatine tonsils. And here we see some structures that are really useful if you've got a base of tongue tumour or an oral cavity cancer for staging. These are the extrinsic muscles, which mean the muscles that are attached to other structures outside the tongue. And when you've got invasion of these muscles, that upstages the tumour. So what are the paired midline muscle here?
Digastrics.
Is it the genio?
Yeah, these are the genioglossus.
Genioglossus.
Yeah, genioglossus. Geniohyoid is right underneath, so as you come down, it may be actually difficult to distinguish the two. But geniohyoid, genioglossus are both extrinsic muscles. And then the muscle out the side here, mylohyoid, great, and that attaches to the mandible at the mylohyoid ridge, and that comes and meets the midline as a raphe. And then between those two muscles, this muscle here,
Genioglossus.
hyoglossus.
Hyoglossus, sorry.
Yeah, hyoglossus. And this muscle is really close to this lingual neurovascular bundle. You can see the lingual neurovascular bundle here. Great. Okay. More of the submandibular gland. Okay. And then this next level is the scary face.
I can see that.
You can see it? Great.
I can see that one.
That means at this level, you and I think the same. This is scary for you. Okay, so the eyes are what? Follicular, right. And then this upper lip of the scary face is what?
Still epiglottis.
Yep, great. Still epiglottis. And then this hat on the scary face is the hyoid bone, of course. And then here, this muscle is that mylohyoid coming down to meet in the midline. And this is the anterior belly of the digastric here on the side. And that's useful for dividing the level 1A from 1B lymph nodes. Okay, this is level 6, and I see an arrow. What is this part of the arrow, the corner here?
Retinoid?
No, close. A retinoid is a cartilage, so that would be high density.
Is it the vestibule? Vestibule?
No, not.
Epiglottic.
Yeah, the aryepiglottic fold. So that will go down to the arytenoid, and that out in the corner here. Yeah, piriform sinus. Yep. So piriform sinus, what is that a subside of? Is that in the larynx or pharynx?
Larynx.
It should be pharynx.
Pharynx?
I think pharynx.
Pharynx. Pharynx. What part of the pharynx? Since you're the best, yeah.
I'm gonna pay for that. I say that to every class. I get them hooked up.
Hypopharynx, great, hypopharynx. And then the aryepiglottic fold or the AE fold, what's that part of? Pharynx or larynx?
Larynx?
Larynx, yeah. So you can see the one's larynx and one's hypopharynx, they're really close together. And so the hypopharynx staging system is much more like the larynx staging system in terms of cartilage is relevant and all those other things. And when you've got a big mass here, it's hard to tell where it came from. Often I look in the notes and I just go along with what they say. But the staging system of the supraglottic larynx is pretty close to the hypopharynx. Okay, And then we've got a bit of hyoid there, and then we've got the anterior belly of the digastric we've talked about. Next level, I'm jumping from 6 to 8. This level looks like a steeple to me, and this is the true vocal cord. And it's a steeple because it's really pointy anteriorly, like a steeple. The anterior commissure at this area is really thin. It shouldn't really be any more than about 2 millimeters. And that, in contrast to the false cord, which is above the true cord, the anterior aspect doesn't look like a steeple. It looks more like a keyhole to me. And you've got a little ligament here. Do you know? I wouldn't expect you to know. This ligament attaches to the epiglottis and then the hyoid. So it's the epiglottis and the thyroid cartilage. So it's the thyroepiglottic ligament. The folds here are the false cord, and often you have some fat on the side as well, which is how I tell the difference. And then the other way I tell is, especially if you've got a humongous neck-eating tumour and you can't see normal structures, the other way I tell is I look at the cricoid cartilage. If I'm really very much right at the top of the cricoid cartilage, then I'm at the level of the false cord. If I'm seeing the cortex and medulla of the cricoid cartilage, then I'm much more likely to be in the true cord. So the way I tell is the thickness anteriorly, fat laterally, and then what's happening to the cricoid cartilage. Am I at the top or am I in the middle? Then finally we get to the cricoid, the only complete ring in the airway. And at this level, note that the mucosa is really thin. There should not be any soft tissue. So this helps you detect the cases of, say, Wegener's with inflammation of the subglottic larynx or small tumours of the subglottic larynx. Then after that, we look at the mediastinum. And then we check at the skull base and look for any bone destruction in that area. So that's the anatomy of the neck. Now we're coming to the spaces, and the spaces are defined by fascia, and there's superficial and deep, and then there's a superficial part of the deep. And I would say don't bother remembering it. Just know that there's fascia in the neck that forms a relative boundary for tumour infection, but it's not a complete boundary if you've got an aggressive infection or an aggressive tumour. The next spaces, the hyoid plays an important role. There are spaces that are both above and below the hyoid, just 3, the carotid, the retropharyngeal, and the prevertebral space. Then there are spaces that are only above the hyoid, and this is the parapharyngeal space, the pharyngeal mucosa space, which is basically the oropharynx and the nasopharynx. And then the masticator space is only above the hyoid, and the parotid space. And then the things that are only infrahyoid are visceral space, which is the larynx, hypopharynx, and then the thyroid. And then anterior and posterior cervical space. And these terms, anterior and posterior cervical space, were used when Hansberger and Smoker first described the spaces in the neck like this for radiologists. But we don't generally call things the anterior cervical space very often these days. And then around the face and mouth, we've got other spaces that I won't have time to talk about as much, and these are the submandibular space, the sublingual space, and the buccal space. So my approach to a case in the head and neck and then spaces is if you see a mass or a collection, try to work out what space it is. And then describe what you're seeing in terms of its margins, its enhancement, whether it's got calcifications, all those things that you would do even for something that was in the thigh. All those are clues to what the pathology is. And then for the neck, I think it's really important because it's really a site where you've got critical structures and you often have very aggressive things, is to check off BMVN. To me it rhymes and sort of rolls off the tongue, but someone said it could stand for Be My Valentine now. But I'm not that romantic. It stands for bone, muscle, vessel and nerve. And any time you've got a big neck mass or collection, go through your mind, is it eroding the bone? Is it invading through the muscle? Is it encasing the carotid or occluding the vein? And what's the potential that it's going to cause perineural spread? because all of these structures happen to be really valuable in tumour staging, whatever the tumour is, and important in terms of deciding whether to resect and what they're going to come to that's going to be dangerous. And then at the end of this, give your best guess diagnosis and then the differential. Very often I get emailed because someone's given a long list of differentials without indicating which one is most likely, and they know that there are times when we're not right 100%, but they still want our opinion. And I think that's just being a good radiologist, giving your opinion, sticking your neck out. Because if Arun and I went to a restaurant tonight and we asked the waiter, which fish do you like? And he says, I like the salmon, the barramundi, and the flounder. And then he says they're all good. I'd go, you've eaten here so many times, you've seen what comes out, which one do you like? And so just as I would want the expert opinion of the waiter, I'd want the physicians want the expert opinion of the radiologist as well. So in the differentials of the neck, we have metastasis and lymphoma are so very common, and then inflection and inflammatory things, and then there are site-specific things. Because of the mucosa, squamous cell cancer is really common in the head and neck. Squamous cell cancer is the most common cause of perineural spread, even though it's not the tumour that's more likely to cause perineural spread. It's just very common. Salivary gland tumours, and they're your mucoepidermoid, and pleomorphic adenomas, adenoid cystic, and then structures, because of the muscle cartilage and bone, you can get sarcomas. So anytime I'm seeing a mass that's a bit unusual, I always throw in it could be a mesenchymal tumour. And then we've got vessels and we've got nerves. Okay, so core cases. Okay, so this is the case, and the question is, Callan, what's the abnormality in this 10-year-old with a fever and painful neck?
Beginning of the retropharyngeal space.
Yeah. Okay. Yeah. And it could be the prevertebral space too. And you definitely look at the vertebral bodies and the disc to see if there's any chance that it could be osteomyelitis. It's less likely to be a pharyngeal lesion because it wouldn't be so diffuse. So retropharyngeal is a good guess. And what other indications for neck radiographs? Well, I don't really see neck radiographs very often. Definitely in kids that have swallowed a foreign body, I would say that's probably the number one reason neck radiograph. Difficulty breathing, still they would probably go to a CT, but in this case they did an X-ray and found that there was an abnormality. And this is a CT with contrast of that 10-year-old child. And we have 4 questions. Where is the abnormality?
All right, so where, okay. I think it's in the left aspect of the retropharyngeal space.
Okay. Yeah. And what is the lateral boundary of this space that you correctly identified?
This is the carotid sheath.
Yes. Yeah. And in particular, I think the internal carotid is a very useful landmark for me. Yeah. And what's the most likely diagnosis here?
I think it's probably suppurative lymphadenopathy.
Yeah, good. Yeah, very good. And is this a surgical emergency?
I don't think so.
Right, good. Okay, so 50% of people would get the last 3 questions wrong. They would call this a retropharyngeal abscess, which is not the case here because that's really an abscess that is spanning the entire retropharyngeal space, and that is alarm bell. Call and get a room in the, I would say theatre, but you call it the operating room, the OR. So you would call and get it drained because it can cause mediastinitis. Whereas the suppurative retropharyngeal lymph node, it could be an abscess, but it's still contained by the lymph node capsule, so it's a contained infection. It's not going to spread down into the mediastinum. And in many cases, it's actually not even pus, it's just an edematous lymph node. And this patient actually has a bilateral abnormality because the other retropharyngeal lymph node here is also enlarged, but it's just not suppurative, and here's the longest colli muscle.
So you look for that bilateral extension to determine abscess versus something
and
that
and this is the case for you, Tim. 13-month fever, working hard to breathe.
So it looks like retropharyngeal space.
Yes.
Again. So this one looks like a permanent fluid collection kind of spanning the entire retropharyngeal space, so abscess.
Yes. Spanning carotid to carotid, touching both carotids. Lateral boundaries, the carotids, the management.
Those would be drainage.
Yeah, in the theatre, right?
In the feet.
And you can see how it's actually causing airway obstruction. The child's actually intubated. Yeah. So retropharyngeal abscess. So there are 3 collections that can occur in the retropharyngeal space. We've covered the first 2. The abscess occurs when this lymph node ruptures into the retropharyngeal space. The suppurative lymph node is just from any infection in the head and neck. This child, you can see the tonsils are pretty large, so they may have had tonsillitis. And then the other collection is just retropharyngeal edema, and that is just obliteration of the normal fat with higher attenuation, and it could just be because of altered venous drainage or altered lymphatic drainage, and that commonly occurs with any infection in the head and neck. In this case, what's the cause of the retropharyngeal edema?
Thrombus.
Yep, in the internal jugular vein. Great. Okay. So kids more commonly get these 2 abscess and the suppurative lymph node. Why is that, Tim?
They generally get more infections. They have more prominent lymph nodes in general.
It's actually because the lymph nodes atrophy as you become an adult. So as a child, this is a common first site of drainage in the upper respiratory tract. As an adult, you drain to the level 2s, which are much more palpable. Yeah. Okay, so all of these collections lie medial to the internal carotid artery, and as a fellow, I would find that people would get them confused, and my attendees would give me different answers, and so I decided to collect a couple of these and write a paper on it. And this is the way I broke it up in terms of distinguishing what space it is. Distribution, the only one that doesn't span carotid to carotid is the suppurative lymph node. Configuration, both the abscess and the suppurative lymph node are much more likely to have mass effect, whereas edema is much less. And then enhancement, the infected collections that are going to be enhancing, the edema doesn't have any enhancement, as you can see. This is a non-contrast CT, so you definitely don't see any enhancement, but if you get contrast, it's unlikely to enhance. And then ancillary findings are helpful, so for the edema, you're going to be looking for, it's going to accompany another abnormality, like a thrombosed vein or a patient that's had radiation or an infection somewhere else. And then for a suppurative lymph node, look for the enlarged tonsils or another infection in the head and neck. That leads me to talk about infections, and this is going to be somewhat covered tomorrow morning, so this is some repetition. Whenever I get called about a neck CT for infection, does that ever happen here? Often. Okay, there are 3 C's that I tick off, and it helps to be systematic here. So collection is the first one. Is there an abscess? That's the number 1 question, because they're thinking, do I drain it, or is it just antibiotics? Next, I think about a cause, and this is particularly helpful for collections in unusual sites. So if it's around the masticating space, you're thinking of what's cause. Dental. Tonsils. If it's somewhere in, say, the larynx, we had an abscess in the larynx that ended up being from a laryngocele that was there. So that was the underlying cause. And then think about branchial cleft cysts, think about malignancies that have had superimposed infection. So that's what I mean about the cause. Try and identify a cause. Parotitis, look for the stone. And then complications. Complications is what's going to cause the morbidity and mortality in that patient. So definitely check those off. And for that, this is my mnemonic, abs. This was the cleanest picture of abs I could find on the internet. The others I went, no, not appropriate. Not appropriate. And this abs stands for airway. So that retropharyngeal abscess definitely obstructed the airway. Blood vessel, does it cause thrombosis? Does it cause a pseudoaneurysm with this infection? And then S stands for spread into dangerous spaces, and that's the chest, and higher up would be orbit and intracranial. So the retropharyngeal abscess, it's from a ruptured suppurative lymph node, causes airway obstruction. It could cause a pseudoaneurysm potentially. I've never seen one because it's so close to the carotid. And then it spreads into the chest. Kids less than 5, because we said the lymph nodes atrophy as you get older. It causes neck pain and dysphagia. That's the usual symptoms because it's so close to the cervical spine and the pharynx. And when they have a sudden relief of those symptoms, they are actually more likely to image. And why is that?
Is it decompressed?
Yeah, because it can rupture out. Yeah, it can, as I said, these fascia are relative boundaries. It can still spread out. So this child, it decompressed out into the lateral neck, or worse, it can decompress into the mediastinum. Yeah. Okay, and this is some anatomy that Connor is learning at the moment. The retropharyngeal space actually has 2 spaces. There's the danger space, which goes all the way down to the mediastinum, and then there's the true retropharyngeal space, which ends in the lower neck, and it's separated by alar fascia that you can't see on imaging. And this man had a retropharyngeal abscess, and it did spread down into the mediastinum, and you can see that he's got fat stranding down the mediastinum. So fat stranding or a collection are concerning. So case 5 is Davis, a 38-year-old female. She had 5 days of right neck pain and stiffness. And I would say this is a tricky case. And she got an MR without contrast of her C-spine because she actually had some right arm symptoms of numbness. So they really felt like it was a neck problem, which it was.
Okay. So, number 1, where is the abnormality? So I'm looking. Okay. So we've got a MRI sagittal of the neck on the left, T2, maybe fat stir,
Yeah.
and then normal
This
T2.
one's a little bit off midline to show you a major finding.
Okay. Looks like the odontoid process looks a little funny.
Yeah, it looks fine in the midline. It's just, you're saying this looks funny?
Yeah.
Yeah.
I don't know if that's just a cut.
What do you think of this?
There's some edema, retropharyngeal edema.
Yeah. And this patient is obviously having difficulty swallowing. He's got all these secretions pooling in his pharynx, right? But it looks like some edema, and it's anterior to the longest coli. These are the longest coli there. Yeah.
Okay, so it's got retropharyngeal
Edema.
edema,
Yes.
most likely diagnosis.
And do you see the collection, which is not really a collection, it's just edema. Then the next C is the cause. And this would be your key image. And as I said, it's a tricky one.
I keep on looking at that odontoid.
Yeah, you're so right. It's very T2 dark.
Dark.
Yeah. So if it's T2 dark, what could it be?
Well, one hemorrhage, old blood, could be like T2 dark. Some kind of calcium.
Yeah, some kind of calcium. Great. Okay, let's say it's calcium. Does that ring any bells? Retropharyngeal edema and calcium.
Longest coli.
Yes, very good.
Calcification.
Yeah. Calcific prevertebral tendonitis. Okay, how should she be treated?
Steroids.
Yeah, non-steroidal anti-inflammatories. Yeah, yeah. So this is another case which would have been easier, but don't give easy cases. This is retropharyngeal edema, and here on the bone windows, there's the calcification around the longus colli muscles. Attachments, yeah. So it's a crystal arthropathy, and then when it gets acutely inflamed, the space that's right next to it, that it is a potential space for fluid to accumulate, is that retropharyngeal space. Yeah. And these patients can actually sometimes have a low-grade fever and mildly elevated white cell count, so that makes it very confusing. But if you see this calcification and the edema, that's slam dunk. You're going to say this is consistent with acute calcific tendinitis. Okay, in the retropharyngeal space, we're leaving it now. We spent a lot of time on it, but the most common thing I see often in the retropharyngeal space in adults is lymph node metastases, lymphoma less common, also lipomas are pretty common. This patient has a nerve sheath tumour that I think they had NF2. Yeah, we can also get vascular malformation. So think about the structures in the retropharyngeal space. There are little nerves and vessels, and then a lot of fat as well, and lymph nodes. And those lymph nodes, I'm always just admiring them when I see them, because they are actually usually very long, because the retropharyngeal space is such a tight space AP-wise. When they expand, they actually grow long. So they end up being the longest lymph node nets that one would ever see in the body. Okay. And if you saw retropharyngeal lymph nodes, what would you think of as the primary tumour?
Swims.
What is that?
Would be swims.
Let's go. Where from?
Base of tongue.
Not as common as this other spot.
Tonsils.
Not as common as another spot.
Nasopharyngeal?
Yeah, nasopharynx, yeah. Nasopharynx is probably the most common cause of retropharyngeal lymph nodes in an adult patient. So although they are atrophied, the nasopharynx drains to the retropharynx first. And then there is any posterior wall of pharynx tumour can go to the retropharyngeal space. Oral cavity cancers can go to the retropharyngeal space. And then there's a gland lower down that happens to be a gland that I do a lot with, the thyroid. Yeah, that goes to the retropharyngeal space as well. And so this patient had a nasopharyngeal tumour. And then this patient had a tongue cancer, and they had submandibular lymph nodes, the level 1B, but they also had a lymph node in the retropharyngeal space. You can see it's necrotic, so that's definitely abnormal. Okay, so don't forget that group of lymph nodes, because it's not numbered, so people forget about them. This next case, Davis, 30-year-old female with right ear effusion and mass.
The abnormality is in the, let's see here. Well, it's on the right. It's kind of posterolateral to the pterygoid plates, which would be in the masticator space.
Okay. Oh, is there another option? It's a good guess, because it is very close and we're not seeing any fat playing.
The parapharyngeal space.
Parapharyngeal space, great, which is right next to the masticator space, right. And let's say it is, we'll go along with it being a parapharyngeal space mass. What are the two most likely diagnoses in the parapharyngeal space?
Parapharyngeal. Well, there's no vessels around there. Lymphoma.
Not as common. Yeah, there's no lymph nodes there in the parapharyngeal space, so lymphoma is not really common there.
Sarcoma.
Sarcoma is always good to throw in, but not not amongst the most common.
I'm trying to think about what lives in the parapharyngeal space, and I think it's just, I thought it was just fat.
There's a lot of fat, yeah. Phone a friend.
Phone a friend, yeah. Gabe.
You've got to phone the neuro friend, not the MSK friend.
Hey now.
But maybe Gabe knows everything.
Definitely not. Squamous is what I was gonna.
Squamous? No, not in the parapharyngeal space because there's not really much mucosa there.
Are there nerves?
Yeah, there are nerves there. Yep, great. Ali's got it. Yeah, the V3 branch goes through the parapharyngeal space. So a nerve, like a nerve sheath tumor.
Yeah.
Okay. Something else? That's number one of the two.
Could it be like a pleomorphic adenoma?
Yes, yes, and salivary gland tumor. They're the top two, because the parapharyngeal space sometimes has a little bit of the parotid extending into it, the deep lobe of the parotid, and also it can just have minor salivary rests in there as well. So they would be my top two. And on the coronal image, Davis, is there something, a sign that makes you favour one of those two, a pleomorphic adenoma versus a schwannoma?
Pleomorphic adenoma,
Why?
because it's got like a cribriform, cerebriform kind of enhancement.
Okay. Well, a schwannoma can also have that because it can
Okay.
undergo cystic degeneration. I've seen a schwannoma that's completely cystic. Yeah.
Invasion into, or it looks like, I don't know if it's a cut, but
Yeah.
maybe, oh yeah, there's a nerve, actually.
This for Raymond. What's this for Raymond?
Frame, is that, okay, let's see here. You said V3.
Yeah.
Styloid, no, that's the facial. Spinosum, or, I don't know.
Anyone?
Well,
Ovale. Yeah. Ovale. Yeah.
So a nerve sheath.
yeah.
Would be more like-
The mnemonic people have is standing room only. S, V1 is superior orbital fissure. V2 is
Rotundum.
rotundum, and then 3 is a valley. Yeah. Okay, so this foramen valley, I don't have the other valley to show you, but it was actually enlarged. So if you've got expansion of a valley, then you're thinking maybe it's a slow-growing schwannoma. Yeah, and especially if you had something on the other side, that would be even better. Okay, and then this is the MRI. Do you think that this adds value in terms of giving you more information? Sort of does, because you now know that it's definitely not masticator space, right? Because what's this muscle here that's just splayed over the top? This is it on the other side. Touches to the condyle.
Medial pterygoid?
Well, this is actually the lateral pterygoid because this is actually attached to the condyle. Yeah, and it's the straight muscle in here. It's just splayed over the top, and it's not edematous. It's not enhancing, so it's entirely in the parapharyngeal space. Yeah. What about the characteristics? I said that after you locate it, you describe the signal and the enhancement and the margins. It's pretty well defined. Both pleomorphic adenoma and a schwannoma can be well defined. It's really T2 bright. It's enhancing vividly. Does that help you distinguish between those two pathologies?
Yes.
No,
No.
it doesn't help at all. Yeah, a nerve sheath tumour is typically really T2 hyperintense, but so can a salivary gland tumour be T2 hyperintense. Yeah, and both can enhance and both can have cystic spaces. So in that case, it's really the bone enlargement of the foramina valley that was most helpful. But either way, this patient needs a biopsy. So this was a schwannoma, V3. What about this next case, Ali? This is a 40-year-old and she had tinnitus.
Okay, so now this also looks like a parapharyngeal
Yes.
space mass.
Yes. And that was just too easy, so I didn't give you that question. But what mass gives low CT density despite having contrast? So this patient has contrast, it really clearly isn't enhancing.
Something that's cystic.
Yep, and of those two masses, the schwannoma and the pleomorphic adenoma.
Pleomorphic adenoma is more cystic, but schwannomas can have cystic degeneration.
Yeah, so the pleomorphic adenoma can be low attenuation even without having cystic components if it's pretty mucinous. But nerve sheath tumours, I don't know if you've noticed, but they are actually always low attenuation on CT. They're pretty much always the same as the spinal cord density. Whereas on MRI, nerve sheath tumours enhance really vividly, so that discordance really puzzles me. But nerve sheath tumours just don't enhance very much on CT. Yeah. So you'll see kids with the plexiform neurofibromas, they're not going to enhance very much on CT either. So something to remember. So low density doesn't help at all. Okay. And my next question is, you know which space it is, the parapharyngeal space. And my next question is, where did it come from? Which suggests it didn't come from the parapharyngeal space.
It has like a little lateral tail coming out posteriorly.
Yeah.
So I think it's coming from, I'm trying to decide if I think it's coming from it's probably the parotid. It's coming from the parotid.
From the deep lobe of the parotid.
Yeah.
Okay. Now there's another, so someone might say, well, it could have been originating in the parapharyngeal space and it's just extending into the deep lobe of the parotid. So why do you think it's coming from the deep lobe of the parotid? And because if it did come from the deep lobe of the parotid, you'd be much more confident that it was a pleomorphic adenoma, right?
Yeah.
Yeah. So what is there? There's a sign on the CT that tells you it started at the deep lobe of the parotid, and it only went into the parapharyngeal space because the parotid was stopping it from the other side.
See, there's like vessels medial and posterior to the mass, but I don't think that helps me at all because it's coming from the parotid space. And then, no, I'm not sure. I don't know why, other than the fact that parotid tumors are much more common than parapharyngeal space tumors.
Or anyone?
That jugular vein is not opacified, is it?
That's not, yeah, it isn't. And it may be just like it's effaced because veins are very compressible. But it's a bony finding yet again. So there's, see that dot there that looks like a vessel?
Yeah.
That's the styloid, and this distance is known as the stylomandibular tunnel or the stylomandibular interval. Can you see the difference between this distance compared to this side? Yeah. So when you've got widening of that once again tells you it's actually originating from the deep lobe of the parotid, and it only went into the parapharyngeal space because it was slowly growing, and this was the path of least resistance because it's a fat space. Yeah. So once again, the bone is really helpful here, differentiating the two, because otherwise a schwannoma can be T2 hyperintense. A pleomorphic schwannoma also vividly enhances, but because of this widening of the space, you know that this is a pleomorphic adenoma, and it's arising from the deep lobe of the parotid. Okay. So now I tell you what's in this space, right, Davis? Should have done that earlier. The two most common things are pleomorphic adenoma and other salivary gland tumours. So you can have pretty aggressive ones, malignant ones, the adenocystic and mucoepidermoid as well, because of the minor salivary gland rest. But pleomorphic adenoma is still most common. And then branchial cleft cysts can occur in this space. You can have other congenital things, cystic lymphangioma. Mets lymphoma infection are less common, just being primarily in the retropharyngeal space. Infection can spread there, but it's not likely to rise from there alone. And it spans from the skull base, it goes to the hyoid. It's a fat triangle. It's got the nerve, the V3 branch of cranial nerve 5. It's got little arteries and little veins. And it's surrounded by 4 other spaces. We, as head and neck radiologists, go on about how displacement of the fat helps you tell what space it's from. So there's the masticated space laterally, then the parotid space, then carotid space, a little bit of the retropharyngeal space, and then the pharynx. So it's really 5 spaces. Here's some examples. This is displacing the fat anteriorly, so this is what space? Carotid, yeah. Here the space is displaced laterally, that's the triangle, and so this is coming from the pharynx, yeah, and this is a masticator space that's displacing the fat posteriorly. And then if you get obliteration of the fat, they say it's primarily in the parapharyngeal space. And so just to show you where it begins and ends, here's the parapharyngeal space at the level of the durum coming down, parapharyngeal space, parapharyngeal space. Parapharyngeal space is behind the carotid, the submandibular gland, parapharyngeal space here, and then parapharyngeal space, and at the level of the submandibular space, it merges with the submandibular space, and then that's where it ends, at the level of the hyoid. This was a child, I think he was about 10, and he had a mass in the parapharyngeal space, and here it's splaying the pterygoid plate, suggesting that it's slowly growing. And I was asked to biopsy it, which I did, and then before the biopsy they got a PET scan, and I thought, why did they do that? It's slow growing, it looks like a schwannoma. And it ended up being a schwannoma. And then the next week I got this case, which was also a child, a middle, primary school age, and this is a mass in the parapharyngeal space, and it is once again splaying the pterygoids. And this was FDG really avid, and I thought, oh, that's why they got it. What do you think this is? It's a tumour that occurs in kids.
Rhabdomyosarcoma.
Yeah, this was rhabdomyosarcoma. So kids don't get schwannomas very often, but rhabdomyosarcoma is a tumour to be concerned about in kids, in the head and neck. So it's a good one to throw in if you've got a paediatric mass.
That was the next week.
That wasn't the same patient, but the next week
Yeah.
on my list, yeah. So it was a good reminder for me. Okay, this is a case, are we up to you, Gabe? Okay. Incidental finding. I love those incidental findings. Okay, which space?
I believe that's, I think it's carotid space.
Great. What's the most likely diagnosis?
So, I would probably say a neural tumor, like a nerve sheath tumor.
Great, okay. Does the CT exclude the other main diagnosis in the carotid space? And look at it, it's really low attenuation, right? Like the spinal cord. I do not lie. At least in my own talk, I do not lie.
No, I don't think.
Does it? What's the other main pathology you think of if someone said carotid space to you?
Carotid space mass. I'm just thinking of a vascular tumor of some sort. I can't think of it right now.
Okay, anyone? Glomus tumors,
glomus.
yeah. And so on CT, a glomus tumor would be, it wouldn't be salt and pepper on the CT, that's an MR finding, but it'd be really vividly enhancing, right? Yeah, on a CT it'd be really vividly enhancing. So this makes this much more likely to be a schwannoma. Okay. And what cranial nerve are you concerned about, Gabe?
The vagus.
Yes, great. Okay. So a vagal schwannoma. Okay, this next case, Sunny.
Right side neck mass. This also looks like it's coming from the carotid space.
Yeah, it's displacing the fat anteriorly. Most likely diagnosis.
Probably, the differential would be the same.
Yeah.
It would be like nerve sheath tumor versus a glomus tumor
Yeah.
slash the paraganglioma, probably paraganglioma here.
Well, glomus tumor and paraganglioma are the same.
Same thing.
Yeah. So which do you think is a nerve sheath tumor or a paraganglioma or glomus tumor?
I would probably say a glomus tumor because it's vividly
Yeah,
enhancing.
exactly. Yeah, we know nerve sheath tumors don't enhance, and at least definitely not vividly. So in contrast to that parapharyngeal space, where the enhancement, the signal doesn't help at all. In the carotid space, it really helps, and more so on the CT than even on the MR. Yeah. So and both of those spaces really have two main differentials that we see more commonly. And yeah, definitely if I had a T2, we'd have the salt and pepper and we'd see flow voids. And that's a characteristic MRI finding if they ask you at the boards. Okay. So vagal paraganglioma. So in the carotid space, we have the artery and the vein, and then we've got cranial nerves 9 through to 12. And then also the sympathetic plexus, and the lymph nodes are really outside the sheath. Okay, and this spans goes from the skull base all the way to the aortic arch. So this is supra and infrahyoid. In this space, lymph nodes adjacent to it are really common, and then paraganglioma and schwannoma are the two top differentials. You can get vascular abnormalities, pseudoaneurysm, and jugular vein thrombosis. Now, I think the artery and vein are really helpful in this space. So the carotid body tumor is between what? Sunny?
Sorry.
The carotid body tumor is between what structures?
The carotid and the internal circular vein.
No.
Carotid body tumor.
Yeah. This is the vein here. So this is actually between two other structures.
Oh, is it? Oh, it's the internal and external.
Yep.
Sorry.
And which one's the posterior one?
The internal is going to be
Right.
posterior.
Yep. Okay, so this person has bilateral carotid body tumors. A schwannoma is usually coming from the vagus nerve, and that nerve actually lies posterior and between the artery and the vein. And so if you're looking for the artery, it's usually displaced anteriorly, and the vein is usually displaced anteriorly as well. And you can see the vein is effaced, whereas the artery is a muscular wall that doesn't get effaced. So that's schwannoma. Whereas lymph nodes are usually level 2A, and these are anterior to the vein and the artery. So if you've got something along the carotid sheath that's anterior to the vascular structures, then lymph nodes are much more likely. Okay, so bit of revision. Cullen, what's this mass?
Separative lymph node.
Yep, this mass. And the artery is lateral. Great.
Right. So that's a schwannoma.
Right. The artery is anterior because the vagus nerve is posterior to the artery and the vein.
And that's also a schwannoma.
But
Right.
in the
In the
parapharyngeal space,
yes.
and the artery is posterior.
Right.
Okay. Great. Okay, we are on to the pitfalls.
I have a quick question.
Yes.
For the glomus tumors, I remember somewhere hearing about it that if you find one on one side to look for the other side, how common is it bilaterally? What's?
It would be definitely it would be 5% roughly, unless you had an inherited syndrome.
Okay.
Yeah, in that case it'd be 25%.
Okay.
I think that's what I remember. Yeah. But not common. But it occurs, so that's a teaching. Okay. We're going back to the front?
Sure.
Yeah. Okay, so this woman, tender mass for 1 month. Ignore where it is located, but what would you give for the differentials here?
All right. Abscess
For a month.
for a month. Yeah. Okay. Like an infected, super infected right gill cleft cyst.
Okay.
Like a lymphangioma. A suppurative lymph node.
Uh-huh. Anything else? If you said suppurative lymph node, what else might you say? Could be infected.
Oh,
A met?
yeah.
Yeah, a met, yeah. Okay, good. And does it need to be aspirated, or do you think?
I mean, I would look at other parts of the neck.
Okay. If there was nothing else.
Nothing else? You could re-image. You
Okay.
could follow it,
Uh-huh.
I guess.
Okay. I was hoping you'd fall for my trick. Okay. Because this was a squamous cell cancer met. And so the point here is, in adults with a cystic neck mass, don't call it a branchial cleft cyst. The person reading this study did. The patient, and then they actually did an FNA, and because the radiologist called it a branchial cleft cyst, the pathologist called it a branchial cleft cyst as well. And then they ended up having a resected. The surgeon is definitely much more on the aggressive side. He said he'd take out incidental thyroid nodule out and do a lobectomy without doing a biopsy. I thought that's. But anyway, fortunately he took this out and it ended up being a squamous cell cancer met. And other mets that can be cystic in the neck are thyroid cancer mets, branchial cleft, but you would probably see more mets if it was from the thyroid, if it had gone up to level 2, unless it was the upper pole of the thyroid. Branchial cleft cyst, definitely cystic schwannoma and lymphatic malformation are possible too. But squamous cell mets that are cystic, what special type of squamous cell cancer would you think of?
HPV?
Yeah, HPV, right, great. Yeah, and so these are HPV tumours. Most common HPV squamous cell cancers are tonsil and base of tongue, and they produce cystic mets. And people, I find it fascinating because my husband is an infectious disease physician, and so anytime my field and his field cross paths, I find that very exciting. But laryngeal cancer has decreased over time because smoking in the dots has decreased. We've just had better public health campaigns. But in that time, oral cavity and pharyngeal cancers haven't decreased at the same rate. So they realised, the smart people that were doing epidemiology realised that this is now not a smoking disease. And then they found that it was actually more young people that were having these squamous cell cancers of the tonsil and the base of tongue. And in particular, it was younger people with a lot of past incidents of sexual activity, multiple partners, and in particular, oral sex encounters. And so this is now a very common cause of squamous cell cancer. At Duke, it's probably about 2/3 of patients with base of tongue and oral cavity. And the fortunate thing is that they have a better prognosis. And they're much less likely to have a second cancer at another site because it's not a smoking field effect. Okay, and other cystic neck masses in adults, this was a cystic schwannoma. It really surprised me, but maybe it shouldn't have because here's the two vessels and it's posterior to that, so it's a good location for the vagus nerve, right? This is a branchial cleft cyst. It's typically anterior to the sternocleidomastoid muscle. If it's a sinus, do you know where it drains to? What branchial cleft is this more likely to be? Second, yeah. Where does the second drain to if it's a sinus? The tonsil, yeah. The tonsil, and then the third and the fourth drain to the piriform sinus, so lower down. And so this was that cystic schwannoma, and then these are cystic mets that are in exactly the same location as the branchial cleft cyst. Here, sort of the level 2A, and here's one further down. What level lymph node would you call this? Just looking at the structures around it. 4. Yeah, I like that. So that would be a good exam question. So just say. I would say know your lymph nodes for the exam. Yeah, I've sat the call. Okay, this is a patient with a lump on the face. It's located anterior to what muscle here, Tim?
Masseter.
Masseter, yeah. And where do you think it could be arising from? Oh, what are your differentials?
So it looks like it's below the subacute fat.
not even, doesn't necessarily have to be the duct, but the parotid. So this is, you didn't fall for this trick. The parotid, there's accessory parotid that overlies the masseter muscle, and it doesn't even have to be contiguous, and it doesn't have to be symmetric. But just know if you're thinking about a mass that's overlying the masseter, think about parotid origin tumors. Yeah. And so this was actually an adenoid cystic carcinoma, but you can't really tell from the pathology unless it's, the imaging, unless it's really invasive. You still say pleomorphic adenoid cystic mucoepidermoid. So I would say a parotid primary is what I usually say in my reports. It needs a biopsy. Okay, so where are these masses? And this just shows where the parotid gland extends to. So you can get parotid anterior to the masseter. You can get parotid, the deep lobe, parotid extending into the parapharyngeal space. So in this location, it's still a parotid tumor. This is a schwannoma. And then you can get parotid masses actually in the parotid. Yeah. The bottom part of the parotid, what is that called? It's known as a parotid tail. Yeah. Okay. Yeah. That's a term that surgeons use a lot. And if they say parotid tail, then I know that in their request for a biopsy, then I know I can do it under ultrasound. Whereas if they just say parotid, I always have to look at the imaging, because if it's in the deep lobes, then I actually have to do it under CT. Like this mass, I would have to go through the face to get to. Something I do not like doing. So the tip here is the salivary gland tissue extends to all corners. Okay. So with the parotid gland, there's a superficial and deep. I've told you that what separates it is the 7th cranial nerve. In the parotid, you actually have lots of lymph nodes, and then you have the retromandibular vein and the external carotid artery. And this is a place to look really carefully when you've got facial nerve palsy. You can get METs and lymphoma infection because of the lymph nodes, and then there's the primary parotid tumors, as well as you can get problems with stones and inflammation and lymphoepithelial cysts. And what two diseases cause these cysts? Sjogren's great. This is to show you where that nerve courses. There is, it's probably easier to start with a CT. That structure is styloid, yeah, and here's your mastoid. And between the styloid and the mastoid, there's the stylomastoid foramen, and it normally has low density fat there. And then on the MR, you can see also there's that T1 hyperintense fat. And the dotted line is that expected course of the facial nerve. This is the retromandibular vein, which you can see really well on both MR as well as CT. On the other side, let me see if I've got narrow. No. On the other side, this person at that stylomastoid foramen, it's not fat, right? It's soft tissue. And then looking out to the parotid, you can see a mass. And same thing on the MR, there's loss of that fat and there's the mass. So this is a good corner to look for if you've got a parotid mass, or you've got a patient with facial nerve palsy. This is not Bell's palsy. And nowhere in the gland could we actually see the thickened nerve, because it doesn't necessarily have to be contiguous, it can skip. And also a lot of the times when you give contrast, the nerve and the parotid gland enhances, so the stylomastoid foramen is actually your best spot to look. Okay. This is an 81-year-old difficulty breathing. Where do you think it is, and what do you think the diagnosis is, Davis?
Okay. It's in the right carotid space.
Yep.
Okay, so what is the diagnosis? Well, there's obliteration of the fat. It's kind of a low attenuating cystic type lesion surrounding the carotid. Difficulty breathing. Infection would be in my differential, like an abscess.
Yeah. So, so the carotid's sort of in the middle, and the whole thing seems like it's wrapping around the carotid, right?
Right.
Yeah. And then here looks like it's at the carotid bifurcation, and there's a bit of the carotid that's protruding into it.
Maybe is that things you would worry about are like an aneurysm.
Yeah.
Pseudoaneurysm.
Yeah.
Thrombus aneurysm.
Yeah, yeah. And it's amazing because she actually had an outside CT and it was smaller, and then it got bigger. So this is a huge pseudoaneurysm at the carotid bifurcation. I can only propose that it was related to atherosclerotic disease. She didn't have any episode of trauma. Yeah. And the tissues of the neck have formed a relative boundary, but it was still slowly enlarging. And she actually had surgery and she passed away from strokes. Yeah. But it was actually getting large enough to compress her airway. So this is a pseudoaneurysm. And I give Ali this next case.
Recurrent nasopharyngeal cancer with severe nosebleed. So.
Yeah. He was, yeah. One of the last cases, I think. Let you guys go ahead.
So we're up past the bifurcation and we're in the ICA.
Yes, great.
And there's like a focal outpouching, which is probably a
Yeah.
pseudoaneurysm of the ICA.
Yeah.
Want to know, like, did he have surgery for his cancer?
Yeah.
Is this the cancer eroding into the ICA and causing a bleed, a posterior bleed?
So he actually, he had radiation, and then he had a recurrence, and I actually biopsied his retropharyngeal lymph node that had gotten larger. And at that time I actually did a CT with contrast because I wanted to see where the carotid artery was, because I had to go through the face. And so I had a comparison, and the artery was normal at that time. And then he had surgery after the biopsy showed that it was positive, and then he bled. So it is, in a way, a pseudoaneurysm, but this is special and different from the other case. And this is not very common these days. Anyone?
Is it no, never mind. I don't know. I was going to say mycotic aneurysm, but it's not like an infection, right?
Not an infection. It's good that you don't know about it. It means that you're not seeing this, and this is not a complication. This is a impending carotid blowout. Okay, this is when you have radiation and then surgery together. It causes necrosis in the tissue, and it causes necrosis in the artery wall and weakening of the wall to cause a pseudoaneurysm. But in contrast to the other case where the tissues around that artery were normal, the tissues around this artery are not normal, and there's gas here. And so that means this artery is directly communicating with this patient's oral cavity. And so when this patient bled, his artery bled out externally. And so the resident overnight here was looking for a hematoma on the next CT, but there's no hematoma or pool of blood because it's bled out.
But it looks so clean around the artery.
Clean, right?
So
right.
it doesn't even look like it just blew out.
No. So this is the complication here is death from bleeding to death. High pressure artery hosing out, and 50% of these patients have a sentinel bleed. So when I came in on the weekend and I saw it, I called them and said, and they were about to discharge the patient. I said, "Don't discharge him. I think he's got a carotid blowout impending." And so he stayed in hospital, and IR. They consulted with IR. The only real thing they can do is really occlude the vessel because it's not really something you want to stent. It's not going to hold it long term. Anyway, he didn't really. They didn't decide on doing anything, and they were going to do an angiogram on Monday, and that was Saturday. And then Sunday, when I came in, he had his actual carotid blowout overnight in the hospital, and it's basically the ENT residents all know about it, even though it's not common because it's such a dramatic death. Watching someone spurt out blood through their mouth and their nose. And so in the end, we didn't save him, and we probably wouldn't anyway because he had a recurrent nasopharyngeal tumour, so he was probably going to die within the next couple of months. But what we did save him from was going home and having his family witness this without any support. Can you imagine that? That would be horrible. Yeah, so on imaging, you're not looking for the contrast or a hematoma. You're really looking for gas and the fact that that contour of the artery is abnormal amongst the tumour and the radiation changes. So the take-home points is anatomy. We've talked about the anatomy throughout the neck. Parapharyngeal and carotid spaces are two good spaces to think about with the anatomy, because knowing the anatomy actually narrows down the differential to two things, and then you've got the imaging findings to help you with narrowing it down to one thing. Retropharyngeal space, think about the 4 steps that I described. The parapharyngeal space mass, think about the stylomandibular tunnel and the foramen ovale. Carotid space, CT enhancement is most helpful. The parotid gland extends to all corners, and in the adult with a cystic neck mass, always think squamous cell cancer. I've seen HPV positive squamous cell cancer in people as young as 35. So it is definitely in a child, you think about a branchial cleft cyst or a lymphatic malformation, but in even a young adult, think about squamous cell cancer. Man, don't let that patient not have an FNA. And that, I think, is it. Thank you.